it can feel so overwhelming. You're like, oh, climate change, like the planet is exploding. And that's how it was for me at the beginning. I was like, what can I do? But I think there actually are like some small things that people can start to do. You just have to like meet the right people.
Dr. Stephanie Maximus is a pulmonary and critical care physician at the University of Pittsburgh Medical Center, clinician educator, and an assistant professor at the University of Pittsburgh. She's one of the co-founders of a grassroots group called the UPMC Clinicians for Climate Action and serves as the representative for the American College of Chest Physicians for the Medical Society Consortium on Climate and Health. During this conversation, we speak with Dr. Maximus about how she got involved with climate action and how others can join. Hi, Dr. Maximus. Thank you for taking the time to connect. I'm looking forward to learning more about you and your work to lessen the impact of climate change.
Thanks for having me.
Yeah. Let's start off a bit about your background. Where did you do your training and where are you now?
So I am from the DC area originally. I went to UVA for undergrad, GW for medical school, and the Boston Medical Center for my residency in internal medicine. Then I actually worked abroad for a year with Partners in Health before coming to Pittsburgh at the University of Pittsburgh Medical Center for my training in pulmonary and critical care, where I now am on faculty.
You mentioned in your article for Chest Advocates that working in Pittsburgh was a catalyst for some of your work within the space of climate change. Can you tell me more about that?
Yeah, I mean, when I arrived in Pittsburgh as a fellow and first started spending time with patients in the office, patients would say to me explicitly, where I live is making me sick. And somehow, even though they basically said it to me, it didn't register quite as deeply as it probably should have at the time. And it took me, about 10 years for it to start to make more sense, I think, as I started to learn more about climate change and the impact of our environments on our health. But the patients would tell me, I wake up in the morning and I see, particulate essentially hanging in the air or covering the cars, or I know that when the industrial buildings around me kind of fire up or whatever, that I know that my breathing gets worse in conjunction with those things. And this is in response to us asking, well, what's triggering your asthma, or why do you think your COPD is worse? And so that was the earliest harbinger of it. And, all that being said, I mean, Pittsburgh is not the industrial city that it once was. Like, it certainly is not what used to kind of call to mind. And yet, even with the kind of changes in, general climate impact of different industries and things like that, we still know that the air that we breathe around us, whether here in this city or in other cities, is not as clean as it should be. And that absolutely affects not only lung health, but so many other organ systems and so many other parts of human health.
You mentioned worsening asthma and COPD. What other issues were they experiencing? What were some of the patients coming in and talking to you about?
That was probably the most overt. Those were probably the most overt things. But one of the most impactful patient stories that I heard, and that actually is the one that got me really motivated to start to think about this stuff, is that I had a patient who was hospitalized for hypersensitivity pneumonitis. Ultimately, I mean, it took us a while to get to that diagnosis. And it was tied to something in his home environment, whether it was inside his actual house or something in that sort of microcosm of his, home or neighborhood. And he was in the ICU. He was initially mechanically ventilated. He needed a long course of steroids. He ultimately recovered. And he did great. He was discharged from the hospital back to home. And then he, through whatever course of life events, he actually ended up incarcerated. And his health was actually okay when he was there. But I saw him again in the hospital weeks after he had been released from prison and had returned back to his home, where his hypersensitivity pneumonitis started again. And just the idea that his health was actually okay in prison, and when he returned to his home environment, his health was worse, was just such a tragic irony to me that, I mean, sure, we want our prison populations also to have great health, but that he was better off from a health standpoint in prison than he was back at home because of something in his environment that was affecting his breathing to the point that he became critically ill yet again, was so dramatic. And this patient was, totally with it, able to explain like exactly what was happening, and had insight into it, but didn't have the means to move away from his home, which most of our patients do not. So that just really struck me. Ultimately, he, again, was like very, very sick. He did high flow ICU, but ultimately got better again. And it just really kind of catalyzed for me this idea that there are things around us that we need to pay more attention to. And that if we just sit back and say, this is what it is, that's really exacerbating so many of the disparities that already exist in our communities.
Wow, that really is a striking story. I'm glad you shared it with us. In your medical opinion, what do you think it was about his home environment that was exacerbating this hypersensitivity pneumonitis?
Yeah, I mean, for hypersensitivity, we usually do a really in-depth, kind of deep history taking about what do you see in your house? What are your hobbies? What are your exposures? And like many times it's something like mold spores in the home or something like that. But really, he didn't endorse any of the usual indoor suspects, but he lived in close proximity to one of the sort of high polluter industrial buildings here in the city, a coke works. And he also knew that with sort of the variation in what was happening with that industrial building, that was impacting his breathing. And he had noticed this kind of process in the past, but it just kind of must have hit some sort of level for him to put him into a position that he was so sick and needed to come into the hospital. So our best assumption is that it actually was none of the usual sort of indoor suspects. He didn't have any unusual hobbies, any of those things, but was most likely something related to the pollutants coming from one of the industrial processes near to his home.
So what do you say to a patient like that when they don't have the means to move away from what's triggering them to be ill?
It's so hard. It's so hard. And that's, I think, where we start to feel a little bit helpless, because you want to help your patient and you want to cure their disease. And we always say we need to get to solve the underlying problem, right? Like we can throw steroids and immunosuppressants and things like that at the disease process. But if the underlying trigger is still there, we're not doing anybody any favors, really. And the patient's really gonna struggle because of all the side effects of the medications that we can use, and also because ultimately, if they're still in the environment that's causing the problem, it may still catch up with them, and our medical therapies may be inadequate. So this is really hard. And sometimes we have conversations about, what options do you have? And can we hook you up with our social workers? Or, talking about, if they live with a family member, do they have family members who live in a different place? But also, we all know, moving houses is not an easy thing. And it's, oftentimes you try to live in the neighborhood where you do have family or where you work, or, there's some reason that you live there, or that's the only place that you can afford. And we know in today's, economy and housing market and things like that, it's very challenging. So this is where kind of I feel like medicine butts up against like social determinants of health and all these like bigger structural challenges that physicians or clinicians in general have not necessarily been trained in how to approach. And I don't think we know what tools are necessarily available to us in our own individual, locales where we're working. And at the end of the day, you might say, this is not really my job. Like, I'm not a real estate agent, or I'm not a social worker. Like, this is not what I'm here to do. And yet we feel deep responsibility for our patients and their health. So that's a really tough question. And I think that there's not one answer. But again, that's kind of like what sparked this question of, well, what's going on? And like, this is not a one-off situation for this one patient. Like, what can we do to improve the health of all of the people in this neighborhood, right? Because even though I'm seeing that one individual and that was his one illness, we know that air pollution causes so many downstream health effects. So even if the patients aren't complaining of their asthma or their COPD getting worse, or their hypersensitivity pneumonitis landing them in the ICU, what in 10 or 20 years is their cancer risk going to be, or is their cardiovascular, health outcome going to be? And we, even though we don't see it today, we or a younger generation of physicians may see it down the line. And so I think we have to ask these hard questions about what options do we have for our patients outside of the office or outside of the hospital room? And also, what can we do in the communities, and how can we be advocates for change so that the larger, whole families and whole neighborhoods health can actually be improved?
You mentioned this feeling of helplessness as a clinician, but you've found a way to almost combat this by working through some collaborative organizations. Tell me about the work you've done to advocate for change.
Yeah, and I have to admit, I did not always feel this way, and I definitely struggled with the sense of like, well, what can I do as a doctor? Like, my skills are limited. And I think it was like right place, right time. This patient I saw in the summer of 2020, and I think there was just this overwhelming feeling of tumultuousness in the world related to the pandemic, related to all of the sort of anti-racism movement going on in the wake of George Floyd. And so I think there was just this sense of, okay, like, I cannot be a bystander anymore. What this degree has to be useful for something outside of the, the building that I work in. And so this got started off for me. There was a group of faculty who teach in the School of Medicine and in all of our graduate medical education programs that got together and wanted to infuse teaching around social justice. And so we had a monthly Zoom meeting, and people would bring different topics to the meeting to kind of educate the group. So it was a really broad, diverse group of faculty members as well as topics, and people brought things that were near and dear to them or that they wanted to learn more about. So it would be things like teaching around disability, there were a lot of topics related to racism, sexism, how do we deal with these things in the classroom, or how we teach these things in the clinical environment. And I had really very little prior knowledge about environmental justice, but it was something that I wanted to learn more about. And so I invited two other colleagues, other faculty members within the School of Medicine who are not pulmonologists. One's an OBGYN and one is a pediatrician, adolescent medicine, sort of health services researcher. And they both have more experience and more knowledge about this than I did, but I invited them to kind of present to this group. And just hearing them speak and having that opportunity to learn together in community was really fantastic and really encouraging. And in subsequent conversations with these two faculty members, I asked them what they were up to, what they were doing, and they were involved actually in a fellowship, fellowship for people who've already completed all of their training, but around around climate change and environmental justice work, I believe through like Harvard and MGH, that they were doing as a group on Zoom, like somewhat asynchronously. And so that effort of theirs was ending soon, but they wanted to kind of take what they had learned from that opportunity and like do the work at UPMC. And so the three of us plus a couple of others came together and we formed a group called Clinicians for Climate Action at UPMC. And we ended up writing a letter that we sent to the leadership of our hospital system. And it was signed by hundreds of UPMC clinicians who are employed by UPMC and the University of Pittsburgh. And we basically were calling on the leadership of our health system to make a commitment to eventual decarbonization of our health system, because of the idea that we all went into medicine and healthcare with the goal of improving patients' health. And yet our health systems continue to contribute to pollution and greenhouse gas emissions and things like that, and ultimately have some harm that is done to the communities that we live and work in. And that just felt really uncomfortable to many of us to think about, well, that's great that we're doing this work on an individual basis. And yet, again, how do we impact the neighborhoods? How do we impact the communities? How do we make a bigger sort of altruistic footprint, essentially, and at least mitigate what harm we might be doing in our environments? And so we wrote this letter signed by hundreds of colleagues, and we actually got a positive response from our hospital leadership, and they agreed to many of the asks or demands in the letter, and subsequently created an office for sustainability, and we've been able to do a lot of really great work over the last couple of years, and it's been a really just sort of really valuable experience, and it's been really positive, and we've met really interesting people through it, learned a lot about this field along the way, and it's given me a sense of purpose outside of my day-to-day job that just seems a little bit bigger and a little bit, it just has meaning there, and that's been really exciting. And I think I have a colleague who has presented on how this can be a way to even combat burnout by like engaging in this kind of climate justice work. And it certainly has been that for me, which has been neat.
Love that as a way to combat burnout. It's an interesting concept that you don't always think about. So in your day-to-day as a pulmonologist and intensivist, you did notice some opportunities to lessen your personal climate footprint at the bedside. Tell me about some of the changes that you made in that day-to-day practice.
Right now, it has a lot to do with noticing, recognizing, for example, the ICU, it's a really high utilization space, as it should be. And yet maybe it has more of an outsized impact than it could have, especially when we compare our impact, our kind of greenhouse gas emissions that come out of an ICU bed here in the United States to our counterparts in other countries. But even things as simple as, what is our PPE usage when we're going in and out of a room? And is this actually evidence-based? Or I've started engaging with some of the HVAC folks and asking questions about how do we generate the energy that is used in our hospital? And are there ways that we can limit this or think about more sustainable options? thinking about food waste when it's as it relates to patient trays that come to patients who are actually never going to eat that food tray or are actually listed as NPO. Like, where's the problem? How is this not being transmitted to the dietary services properly? We think a lot about the medications that we're using and what are all of the kind of supply chain issues involved with that. As a pulmonologist, it's so important to know and learn about the tremendous greenhouse gas output of our HFA inhalers, which our simple albuterol inhaler that we sort of prescribe willy-nilly and gets thrown around, and people have 700 of these extra cartridges lying around and may or may not be using it appropriately. That has one of the most highest amounts of greenhouse gas emissions in the entire health system, actually. So that's become sort of a project that I've become very interested in, thinking about how are we going to approach our sort of HFA prescribing, dispensing. Can we favor better alternative options in the appropriate circumstances? So there's an endless number of projects. I have an anesthesia colleague who's focused her effort initially on eliminating the use of desflurane in our health system. And it's one of the kind of worst offenders as far as pollutants. And sure enough, we no longer have it on our formulary. And so that's one of those kind of low hanging fruit things she was able to get done really rapidly and has a tremendous impact across an entire health system. And I think many health systems are working on a project like that, which is pretty easy because there are so many other alternative, better options to just kind of get rid of the thing that is causing the biggest problem when you have better alternatives. Albuterol HFAs it's not that easy. It's not as simple, which is also partly why it's also very interesting problem to be thinking about because it's so multifactorial. The same anesthesia colleague is thinking carefully about in the sort of perioperative spaces, the use of disposable pulse oximeters for these patients who are not critically ill and not flailing around like maybe many of our patients are. Using the reusable pulse oximeters and then just cleaning them between patients actually can work perfectly fine. And so she did a great analysis of not only the environmental impact, but also the cost impact of not purchasing and throwing out all of these pulse oximeters. And so her hospital and kind of unit is switching to reusable devices. So it raises the question of, what other single-use plastics should we be thinking about reprocessing and sterilizing? During the COVID pandemic, I think many of our hospitals moved towards near universal use of single-use disposable bronchoscopes. But is that the right move? And actually, should we be going back to our reusable bronchoscopes and sterilizing and reprocessing them? So that's an example of something else. Just asking the questions and then linking up with the people who can do the analysis about what is the right thing in my environment. And I think is the most important thing for folks to start to do.
Asking the questions and finding the people who can do the analysis. That's a great way to go about it. But it's something that is bigger than just you, than just your institution. You recently were selected to be the CHEST representative for the Medical Society Consortium on Climate and Health. Tell me a little about the consortium and what you hope to accomplish through your work with this organization.
It's a really cool organization. They do tremendous work, and it's nice because it is really diverse representation across all of medicine. So it's mostly it's a group of physicians who are just motivated by this, and they represent different professional organizations largely. So, for example, like the American Association of Pediatrics has a representative there. And I will say PEDS is way ahead of adult medicine and advocating for issues around climate change, perhaps because pediatricians are just great advocates, but also because we know that children are at much greater health risk from even the same doses of air pollution that adults may be seeing due to their kind of body mass. And we know that they'll probably experience longer term effects over time as our climate is changing. And so this group gets together. We've now recently named a series of kind of subcommittees that are working on different things. So there's a policy subcommittee. There's an education subcommittee, for example. So that's the one that I've been working a little bit more with. And within the education subcommittee, some of the things that we're thinking about doing is how do we provide this education? How do we just kind of spread this knowledge about what's going on in our climates to all of the physicians kind of nationally and in our organizations? Because I think while there's been a huge call for this education from medical students in school today, many of us who graduated years ago were not taught this formally. And if you have any interest in it, maybe you've dug into it, you've done some reading, you listened to some podcasts, but otherwise there's not an easy way to kind of get this knowledge. And yet we see our patients' health being impacted by it. And maybe we even have patients who ask explicitly about, what do I do when the wildfire smoke is wafting into my home every summer? Or what do I do if I, work in a certain industry? How do I protect myself? Or how do I help my child when the EPA is code red for today and I have to send my kid to school? So some of the things that we've thought about as an education subcommittee is distribution of resources and educational opportunities through our various organizations. And CHEST does such a great job with education. So I think that we're going to play a really pivotal role in that space. And then also, how do we partner with our board certification like liaisons to actually start to emphasize this as a necessary area that clinicians should know about. So not only if people are interested, how do they get the information, but ultimately, like, we need to know this information. There's an urgency. And so by kind of talking with folks who direct some of these board certifications, by them starting to create materials around this, I think it will sort of raise the importance of it and the urgency for folks to start to learn about it and to know that it's a necessary part of our practice.
So those listening to our conversation may feel compelled to follow your lead. What can your fellow clinicians do to contribute to tackling the threat of climate change?
Like I said, start to ask questions, start to notice. I think things around you that inspire you are the best things to start to latch onto. Do what you can to meet other like-minded folks where you work, whether it's in your practice, in your hospital, in your health system, in your, if you're affiliated with a university, or through your professional organizations. So, for example, through CHEST, and I think we're starting to gather a growing group of folks who are really interested in this topic, and to say, okay, well, how do we put our heads together and our skill sets, right? I don't have deep data analytical skills, but if you do, like, that would be super useful for thinking about, how do we do larger projects kind of across health systems, for example. Or if you have a big outpatient practice, kind of like, how can we look at your patient population and think about, well, what is it that group needs? Or maybe you're thinking more about the sustainability aspect and you say, well, how do I just make my office have less of a climate impact in my community? And we can, how do I get access to resources about greening my office space, which that is the kind of thing that exists. So I think thinking about what it is that inspires you, thinking about the microcosm that you live in, and connecting with people either local to you or that you have connections with through CHEST or ATS or any of these other groups is probably the best way to get started. And I think hearing about what projects are kind of either low-hanging fruit or like most easily accessible or is the most urgent for your patients or for your clinical space that you're working in. That's kind of the way to go. And I think definitely finding a critical mass of people was very important for me. It's hard to work in a vacuum. It's a heavy lift, but kind of joining up, I think even if you join up with one other person, I think you can move a mountain. So, and it's felt that way for us here, and connecting with other folks nationally through CHEST and through the consortium has demonstrated to me similar stories in other places too.
It really is power in numbers, and this is just another example of that. This was a lot of really great information. Do you have anything else to share with this group?
Really, honestly, I'm grateful that CHEST has gotten excited about this because I think there's huge promise in us engaging with all of the, clinicians and that are part of the organization, as well as the organization itself. I think CHEST has an interest in thinking about its own climate impact, which I think is fantastic. And there's definitely a movement around organizations. How do we kind of green our professional society? And so I think also from kind of the staff of CHEST perspective, I think there's great opportunity there as well to sort of do this work and to take pride in that, because I think we all, our jobs are our jobs, but we all want to work for organizations that are doing the right thing. And so I think it's just another opportunity to kind of make that kind of an impact. And I'm grateful that CHEST got excited about it, and that there are leaders within the organization that want to value this and want to be kind of a big advocate. So I think we can have tremendous positive impact, and I'm looking forward to that.
Well, we're looking forward to seeing the work that you do with the consortium on behalf of CHEST. So thank you again, Dr. Maximous, for taking the time to connect and to share the work that can be done in this space. It really was very great to hear about.
Thanks so much.
Thank you for listening to today's conversation with Dr. Maximous. For more on climate impact on lung health and related advocacy work, visit the CHEST website to read the latest issue of CHEST Advocates, which explores the health impact of climate change and environmental injustices.